Welcome to another episode of Rethinking the Drops with iDose TR. Last time, glaucoma experts shared insights into patient selection and access for this treatment. In this installment, Dr. Funke speaks with Dr. Zarmeena Vendal and Lisa Feulner about how surgeons can operationalize the use of iDose TR and integrate this procedural pharmaceutical into their glaucoma treatment armamentarium.
Hello, everyone, and welcome to yet another podcast about iDose TR. I'm going to be the moderator here tonight. This is Funke coming out of Phoenix, Arizona, cataract and IG specialist. And I have two amazing co-hosts with me, both female, so an all-female crowd tonight, which I can't help but shout out. So if you don't mind just introducing yourselves.
All right. So great to be here, Christine. It's Zarmeena Vendal. I'm a cataract, refractive, and glaucoma surgeon in Austin, Texas. Been here for 20 years and excited about being involved in the world of IG.
And I'm Dr. Lisa Feulner. I practice in Bel Air, Maryland, right outside of Baltimore. I do refractive cataract surgery, IG, glaucoma, and ocular surface disease specialty. I am excited to be here to talk about this exciting topic.
Good, because I'm excited too. So tonight, the big topic we're talking about is really how we have all, as a unit, operationalized the use of iDose TR, because I think we've really done a good job as a unit of glaucoma specialists as well as general ophthalmologists of talking about why we want to integrate procedural pharmaceuticals into our armamentarium, but now really starts to talk about how have we done it, because it's easy to say why, but then actually implementing sometimes can be a challenge. So that's going to be kind of our goal for this evening, is to really talk about each of our journeys towards operationalizing the use of this procedural pharmaceutical. So I think let's start with talking about how this has gotten integrated into your practice and also what barriers you guys faced.
For me, the biggest barrier was me. I was the biggest barrier to pretty much implementing anything that we do in our practice. And really getting into that interventional mindset, believing myself that doing something interventional for the patient was the right thing, that it was the safest and most efficacious thing. And once I overcame my own limits and my own confidence and my own inability to accept that a surgical procedure was better than what we traditionally were using to treat glaucoma, I think it was easier for me to have that conversation with my staff, with my ODs, my referring doctors, and definitely with the patients, because I think they feel your confidence and they feel your passion for doing something that is going to truly change their lives.
I agree. How did you get to that place? Because I think that's a barrier a lot of us are facing, is really, again, you're right, ourselves. And how did you finally kind of have that light bulb moment of saying this really is the right path for me and for the patients?
I think it started because I mean, I've been doing SLT for, more than a decade and a half, been a long time since I started with SLT. And that journey took me to believing for that should be, my first treatment of choice rather than drops. I think that being frustrated and not feeling like I was taking good care of my patients, sometimes not knowing whether or not they were progressing in their disease because I hadn't lowered their pressure enough, or were they missing their drops, that sort of ambiguity that I felt almost every day, and that frustration and feeling like I really didn't have a good way of controlling their disease pushed me into wanting to do something more definitive that had data and safety behind it. The access of iDose TR to my armamentarium was just the icing on the cake. I really felt like now there really wasn't a reason that I needed to choose a drop over something interventional, and that the iDose TR just solved so many of the problems in my questioning of why these diseases were progressing. It just solved it for me. So it's sort of a no-brainer at that point.
I love the thought you brought up earlier about, there's a difference between efficacy and adoption. And that's been a real eye opener for all of us who've been practicing in the glaucoma space. Like SLT, as Lisa brought up, is such a great example. Why do maybe 90% of us think that's a great first line choice. And yet, half or less of us actually offer it as first line. And that's when the reality of the pain points set in for us. And my desire, again, to rephrase what Lisa said in a slightly different way, is how do I implement a company culture, an internal mission amongst all the doctors that we duplicate similar care? That was the big thing. Then the aha moment for us was that we could have way less variability amongst all of us if we were more interventional. And to kind of paint the picture, our practice is a 5 location practice with 7 doctors. We have 2 internal ODs and 3 of us who are surgeons that could all be managing, all 5 of us, a glaucoma patient at any given time. So, what is our algorithm? How do we treat that glaucoma? Which drop first? Which drop second? There's just so much variability. So, for me, as the medical director of this practice, I came to realization that, gosh, the way to normalize our care, or rather have the same delivery of care no matter what location, no matter what demographic of patient, no matter what subspecialty and level of training of all of us. The only way to do that was to be interventional. And so that mindset needed to come into play first. And once we realized that internally, then it was about executing. And this is where our CEO and other key members really came into play. And that is internal education amongst all of our doctors to say, look, this should really be the standard of care if we want all of our patients to have similar results, and if we want to curb their glaucoma journey similarly. A big piece of that is that diurnal variation. God, it keeps you up at night when you think about pathophysiology of the condition. How do you know if they're fluctuating or not until they've shown up with a brand new visual field defect and the whole time you thought their pressure was at 15? So, another sort of pearl there to say, why to turn interventional. And so that was, I guess, another piece is to really feel like we were curbing the disease in some sort of interventional universal fashion.
I love that. And I think you're right that it does. I think Lisa had the best point of first stating we have to start with ourselves. And then Mina then brings it to, then we have to bring it out to our community. And when we're talking about bringing it out to our community, that's kind of where I was thinking I was going with my biggest barrier was, yes, first I had to like discuss with my own self, what's my algorithm? What's the way I want to treat patients? And once you realize the best way forward is interventional glaucoma, and you can put in that box all the different tools that we have, and trying to minimize the use of pharmaceuticals topically, because we know unfortunately compliance is always an issue and diurnal curve is always an issue. Once I got there, then it was talking to my community and understanding what that looked like. And for me, I learned maybe the hard way a little bit that I really needed to be very concrete with my thoughts on what I wanted for management of all the glaucoma patients within my practice. And I realized I needed it written down. So, one thing that I think was kind of a pearl for me in helping to disseminate the information once I decided for myself that I really wanted to be very pro IG was, again, writing down an algorithm, writing down a very specific protocol that I could then bring out to all of my referring MDs and ODs. And that has really changed a lot of the trajectory of what I'm getting in terms of referrals back. Because interestingly, I think a lot of my colleagues were actually nervous to send the wrong patient, which I thought was really fascinating. We talk a lot about in glaucoma about we're getting patients too late, but it's, I think, because we're not giving the permission to send them early. And so people feel like, oh gosh, I don't want Dr. Funke to look at me and think, why would she send, why would I send this moderate 1 med patient? No, the opposite, right? We want those patients now. And until I communicated that very bluntly to all of my referrals, I wasn't getting the amount of patients I wanted. Now that I've been open and saying I want all those patients, I want to care for them, then I want to send them back to you. That's really when I started to see the pattern of flow change to me. So that was kind of one thing I noticed as a barrier initially that became eventually, once you kind of break that down and realize where everyone's really fear is around becoming more IG, and it's different depending on what level you are as a provider. That changes the game for everything. And then once I did that, of course, my last step being in a very large practice with a an abundant C-suite is I then had to talk to them about how this fits into the practice model and how it behooves us as as an organization. Did either of you guys have to kind of talk on the C-suite level at kind of in a different way about why this is important in integrating procedural pharmaceuticals as part of, a buy and build model at that? So it's something very different.
Yeah, I think there definitely has to be buy-in with your administrative staff, no matter how, big or large. It's funny because we as surgeons are the rate limiting step, aren't we, to start with? And we limit ourselves, I think, when we don't learn all the tools that can possibly be there to widen our toolbox. However, once we get there, there's a whole another a bit of buy-in that has to happen administratively on a day-to-day basis, clinically, to help execute our vision. And that is a key part of what it took for us over the last many years to really turn the vision into reality. And so there's definitely a lot of educating that needed to happen with my CEO and our operations person to say, hey, this is also about efficiency. This isn't just about disease prevention. We all know and take that as a given, but we can actually improve our internal efficiencies by doing things like interventional glaucoma, whether it is fewer callbacks due to eye drops, side effects, how many patients not only discontinue their medicine, but are lost to follow up when we treat them with medicine. And then the efficiency we can create within our clinics that the surgeons can really almost have a surgical consult like clinic, almost like an IG clinic or IG visits if our internal ODs and our community referral sources are educated appropriately. So it doesn't take very much, I think, to have buy in once you really explain it on that level, that this can is not only good for the condition and the patient, but also in the day to day runnings efficiencies of the practice.
I think both of you had such great points, and I want to address one thing that you said, Christine, and that is the perceived barrier from the doctor, staff, and community referral base. And I say perceived because we think that we're going to have a hard time convincing all of these people that this is the right thing. And in truth, the community doctors love this because they really don't love treating glaucoma. They don't love doing prior auths for drops. They don't love a lot about the uncertainty of what's happening with their patients. And once I educated my community doctors, we held dinners and talks, and I opened myself up to virtual consultations for patients. The floodgates opened. We've never been busier than we are right now because they're sending us these patients early. We're managing them. They get to follow them in a very confident way for them. They're managed. And when they have questions, they send them back. And if they need an intervention, we take care of it. We send them back. And for the community doctors and even our doctors in our practice, this is very appealing because we all are doing what we're really trained the best to do, right? We're surgeons who should be doing surgery. And that leads me into what Mina was saying. And I come from a very large C-suite setup as well. And like you said, writing things down, like almost making a pro forma where you feel like if you can set this up the way it should be with, optometry doing the primary care of the glaucoma patients and you as a surgeon doing the surgical care, the pro forma on that for the practice speaks for itself. And it also frees up people in the office that might have been spending their days doing prior auths and calling patient back and scheduling new appointments for drop changes, drop intolerances. Those people can now go to the clinic. We have someone who's now in the clinic 2 to 3 days a week doing visual fields and OCTs instead of answering the phone. So those, C-suite are about money, right? They're about money and efficiencies. And this is such a beautiful model for that. So not only do the patients get great care, the best care we can give them, but we're also able to design our practices in a way that are not only efficient but productive. I said, let me just do this and show you. And sure enough, it really worked. And the surgery aspect, the surgery center aspect, the key there is start slow, easy, and simple. One patient, two patients, take the surgery center through the procedure and the follow-up to billing and reimbursement. And once they see that this can be done, even if there is, an upfront cost to the surgery center, but they're going to get paid, and like in the case of the iDose TR, it was seamless. We just had to get the first patient through, and then again, the floodgates were open. This is not a big deal. This is something that can happen when we need it to happen. And I think, the keys came from your idea of writing things down, developing that pro forma for your practice, and then educating everyone with the passion that we all feel. And then, I think when people see that and feel that, it's not that hard. I mean, it's in our head again. Those barriers are in our head.
And I think the buy and bill part is important to mention because I would say the one thing that we have to remember is to set ourselves up for success and do the homework and create communication right between the three parts, which is, us in the clinic, the codes that will, get us paid as a doctor, and the surgery center, and then insurance verification. So to create this nice kind of communication where everybody's on the same page takes a very little bit of time, but is worth it. And that's where, at least when we started over a year ago, the company responsible for iDose TR, Glaukos, was instrumental in helping us, especially with verification of patients. But buy and bill isn't something foreign to us. For example, Dextenza and other things that we've used in the OR work exactly the same way. And there's great ways for even the surgery center to feel those efficiencies if they're ordering the medication, the procedural pharmaceutical, and then there's a delayed billing, if you will. And many times they've already been reimbursed by the patient's insurance by the time they have to, pay for the bill. So these sorts of things were important to put into place. And as soon as they were put into place, we really just haven't had any issues because we're very cognizant of our particular entity and insurance entity and everything that's been covered. So I just think it behooves us the same way in the clinic that we are with our administrative staff to really make sure that we extend that kind of level of communication with the surgery center too.
And I think Glaukos does do an excellent job with a lot of hand holding at the beginning here. So if it's somebody who's listening who's just getting started, that's something where they have a lot of resources to just make sure that you are picking the correct patients in terms of reimbursement. I think that was really helpful at the beginning. We have now gotten to a place because that was a barrier as we started to increase our volume of ensuring that we were not offering this to people who couldn't get it. So we ended up making our own kind of breakdown of all the different major payers that we have. And we actually made something that's a constantly modified document that's available on our website personally, internally, so that we can look up every single patient to make sure if that's available or not and what may or may not be needed in order to get an iDose TR available to the patients. That's been super helpful as well. Because again, it's nice to have a lot of tools in terms of Glaukos. However, at some point you're going to get beyond that and you're going to want your own internal tool. So that's been really, again, a kind of a nice push to the next level when people get there.
Yeah, I think those internal tools especially apply to the clinic when it comes to finding patients and patient candidacy, and I can't say enough about educating all the layers of staff that you have in the office, from the front office all the way to the doctor. And so for us, we have clinic leads, for example, and they might have monthly meetings where there's education going on with the techs. And that's a great way to dissipate information or that algorithm like you're mentioning to really help our staff help us identify patients. And so I don't know if you found that helpful, but we sure did. That we don't wait necessarily till the patient is in my lane for me to decide if they might be a good candidate. Many times I've already I've already gotten a hint from my tech that this might be somebody worth looking at. And it requires our staff to really be proactive in asking the questions. And there's just it can go a long way if the training is up front for the techs to really start to identify patients, for example, that are having trouble with their copays, that are having trouble with insurance coverage, that are having worsening ocular surface disease, and just aren't really mentioning it until they're asked. And so it's this level of like patient identification that you can really run with too, when it comes to creating these algorithms internally. And so that's been very helpful for us in terms of just finding candidates.
I love the idea of using your staff that way because I do the same. And I think one of the big barriers I hear people talk about, where get to talk all of us at a lot of with a lot of different MDs, and I think one of the big barriers is I don't have the time to discuss all the options with the patients, which sounds like in some ways a barrier that can be easily solved. And I think exactly what you're saying, Mina, is the solution, which is you need to educate your staff around you because I'm with you. By the time I get into that room, the likelihood that they haven't heard about the options is very low. And it's because my staff is super educated. They're with me all the time and we talk about IG ad nauseum, but also they're really excited about it because they've seen how happy patients are post-operatively and they get to see how thrilled patients are to be feeling better, to be less medication dependent or independent of it, how happy their families are who maybe are helping them and supporting them with drop therapy. So I think the more that the staff understands the positive impact you're having, not only on the clinic, but also on the patients, the more that they want to get involved. And then they become your biggest advocate and liaison before you even walk in the room. And then that barrier suddenly kind of slips away, right? You're going to talk a little bit about whatever you want to do, but half the time I'll walk in and they'll be like, "Oh yeah, I already heard about, that stent you're going to put into the eye."
Yeah, we do a lot of education. I mean, so many of your points we practice very similarly. I think the three of us, we revisit education. Like tonight, and for example, we were supposed to have a dinner with staff, but we have snow here, so this kind of got derailed, but it's rescheduled for next week because there are some challenges. You get new staff, or there are some things that come up, and what is the language we're speaking. So we have a meeting periodically, and our Glaukos rep is she's always touching base, and she's always bringing us pearls back from other practices about how things are done, or she's talking to my staff and saying, hey, what are your difficulties? And that's been really great. So touching base with your staff to make sure your mission and your message are constant all the time, even if you have new staff members. And the other thing is, we communicate by sticky note in our electronic health records. So when an optometrist has a conversation with the patient, they write a message in the chart that says, have discussed this with the patient very interested. The techs ask the questions every time. Are you having a hard time putting your drops in? How are you tolerating your drops? Do you ever miss a drop? And all these little tools key us who have limited time into very quickly identifying the patients who need and want this. I have patients who call in asking for it that I've been taking care of because we use something called Brevium, which pulls the CPT codes for patients. And then we use another service called Navigate that has navigators that actually call with a script that we've designed and discuss it with patients that are having an appointment coming up. And if they're seeing the optometrist, it's sticky noted in their chart. The optometrist now knows that that patient is interested, and that path to me is very short. So like Mina said, like having conversations and that communication loop is very important. And I think touching back and not assuming that your wheels are turning efficiently, but making sure that you're seeing or hearing about any glitches along the way. And I think your idea, Christine, about having that list of insurances, and they're either like red light, yellow light, green light. So the low hanging fruit or the green light, maybe you need a prior auth or look into this one a little bit more, are the yellows. And then the reds are like, we know you're not going to get covered. So, right now we're still working on maybe developing this coverage, but don't spend a lot of time with this person. They're probably not going to get covered for this procedure that you want to do. And that is amazing, right? Because everyone has access to it. And like you said, you can change it all the time as these insurance coverages change. So I think we do a lot of the things the same among the three of us.
We're doing our job right. We're creating a company culture and then we're extending it into a community culture, right? And so not only are we thinking from an interventional standpoint internally, but it's now starting to get to where the patients are already coming to us as new patient evals, already having heard about iDose TR. And that happens frequently. I saw a patient just today who notified me that the optometrist that was sending him in had already mentioned iDose TR to him. And it felt great because maybe we succeeded in moving that IG need a little bit through all the education that we've done. So it's just a, almost a Venn diagram, if you will, of three different parts that should, if we're doing our job right, intersect. And we should all be doing things in an interventional fashion. The other way that I end up seeing a lot of surgical consults and consults for procedural pharmaceuticals, again, is from our internal ODs. And I think I saw at least two people today who, perfect example, failed SLT or pseudo fakes who had surgery and now have been drop free, but their pressures are going up. And the optometrist internally has already had the conversation with the patient about needing something like iDose TR. So it just makes the whole process seamless and it makes us really feel good, I think, to feel like we really move the needle for these patients from all aspects, not just what you and I and the three of us are doing in the lane, but what everybody's doing.
One of the things that I hear from a lot of doctors that I talk to about it is a couple things. One is their discomfort with the angle. And the second is, what do I do in the middle of my busy clinic and try to make this happen? And I experienced that. So when I started, I just threw them into my 25 cataract surgery day where I was doing femto and premium lenses and torics and all of this stuff. And adding into that, turning the head, turning the microscope, putting an iDose TR in, I was exhausted by the end of the day mentally from trying to remember what I was doing and adjusting my brain throughout the day. And so what I really did was I put all of my glaucoma patients on 2 days a month and they're clustered together so that I'm always doing the same thing and I'm not trying to throw them in the middle of a very busy, other surgery day. And I think that, even if you're starting out and you don't have enough, at least cluster them either in the beginning or the end. Don't try to scatter them throughout the day because it's exhausting to try and shift your mind constantly through the day. So that's one thing that I've had an opportunity to talk about with other surgeons.
I love all this advice. I think it's amazing. I hope it helps a lot of people out there either get started on their journey with iDose TR or help even get over the hump of, just getting started. Let's close out with each of us giving one little piece of advice for those who have used maybe one or two, but they haven't really found the groove yet with iDose TR.
Yeah, absolutely. I think that's really all of our goal is to utilize in a way that we're affecting as many patients as possible. And I would say to all my colleagues, think of it as a patient-centric approach instead of just treating the pressure. Let's start to look at all of the pain points that our patients experience on a day-to-day basis, uh, and really start to ask them the questions of whether they're having difficulty in their quality of life and their ADLs as a result of the medications that they're on. And we will start to uncover way more candidates than we thought were present. And so just extending the conversation in the clinic and really identifying patients who are having trouble with the journey of glaucoma and eye drops instead of just reacting when we see an eye pressure we don't like. And once we find those candidates, I can't stress enough how important it is to make a firm, confident recommendation as a surgeon, because I don't think patients who are on a glaucoma journey and at the end of the day afraid of losing their sight will ever say no when they feel like there's an opportunity to control their glaucoma better. So that firm recommendation would be my second piece of advice.
I think, in the clinic, just like we have scripts for everything we talk to our patients about, developing a script to discuss with patients why you think this is the right thing for them. As long as you believe it and you're passionate and you have a concise way to share that knowledge and that passion with the patient, the clinic barrier becomes smaller, because you've developed an efficient way and a confident way to have that conversation, but you have to convince yourself first. And then again, in the OR, I would say to get over that hump, so you want to do more, would be to get as comfortable in the angle as you can, and don't put it in the middle of a busy day. Just sort of sequester them in the beginning or the end of any day that you have, so that you can focus 100% on what you're doing.
I love it. And for me, I would say look at your data. If you've done a couple, look back and see what impact you had on the patients. Even better, if you be able to talk to them and see what kind of impact decreasing medication burden really did for them. I think that really helps get you enthusiastic to do more, because when you start to get the thank yous and the hugs, that's, I think, such a positive motivator to do more. Um, I think there's nothing better. And then if the barrier for you is your clinic and clinic burden, slow down how many patients you're seeing. I've done that myself, and I think it made a huge difference, because I kind of tailored my clinic to being able to see just surgical consults, which was uncomfortable a little at first, kind of letting go of the complete control of every glaucoma patient. But if you really want to touch everyone's life, you've got to let go of those who are doing well, and let them be cared for by others who can do that clinically, and open yourself up for more surgical options. But that also means, again, you don't need to see 70 patients in a half day. I mean, it's too many. You really need to slow yourself down a little bit and open yourself up to slightly longer time and maybe more satisfying time with the people who really still need solutions to their disease. So with that, I want to say thank you guys so much for joining us. I hope you enjoyed the podcast. I know I did. I think this was a really awesome topic, and I think a topic that's really needed to discuss more about how we're going to integrate more of interventional glaucoma into all of our lives and our practice. So thanks for joining me, you guys.
Thank you for listening to another installment of Rethinking the Drops with iDose TR. Be sure to listen to our third and final episode to learn more about how to discuss iDose TR with your patients. Indications and usage. iDose TR, travoprost intracameral implant, is indicated for the reduction of intraocular pressure, IOP, in patients with open-angle glaucoma, OAG, or ocular hypertension, OHT. Important safety information. For ophthalmic intracameral administration, the intracameral administration should be carried out under standard aseptic conditions. Contraindications. iDose TR is contraindicated in patients with active or suspected ocular or periocular infections, patients with corneal endothelial cell dystrophy, example Fuchs dystrophy, corneal guttate, patients with a prior corneal transplantation, or endothelial cell transplants, example Decimase stripping automated endothelial keratoplasty, DSEK, patients with hypersensitivity to travoprost or to any other components of the product. Warnings and precautions. iDose TR should be used with caution in patients with narrow angles or other angle abnormalities. Monitor patients routinely to confirm the location of the iDose TR at the site of administration. Increased pigmentation of the iris can occur. Iris pigmentation is likely to be permanent. Adverse reactions. In controlled studies, the most common ocular adverse reactions reported in 2% to 6% of patients were increases in intraocular pressure, iritis, dry eye, visual field defects, eye pain, ocular hyperemia, and reduced visual acuity. Please see full prescribing information. You are encouraged to report all side effects to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. You may also call Glaukos at 1-888-404-1644. PM US 3387.